Okay, hopefully you've made it to number 3 here. This is the third category. We're looking at something that people are very not aware of, and that's their bite characteristics. Dentists also don't quite look at this enough because they're mostly doing tooth by tooth dentistry. When you're looking at full arch rehabilitation or more advanced general dentistry concepts or prosthetics, you have to really look at how the patient actually bites and how their jaw comes together. And one of the reasons why it's so obscure is that your brain does not actually think about your jaw in its position so much until something is changed. And any change to your mouth is a negative to your mouth. Very seldom do I say, oh, now it's all feels perfect now that you do something. Every time you do something, you add a crown, you change a prosthetic, it feels extremely foreign. And with bite characteristics, we're looking at how your jaw comes together. I call the jaw a one-hand clapper. It's kind of like you have your upper jaw here, it's stuck to your skull, it doesn't move, but your lower jaw is just kind of coming together like this. Now the other aspect of your jaw is that your jaw joint's a very unique joint in your body. It's not like your elbow that just goes in and out, maybe does a little bit of back and forth, but it's mostly a hinge. This is not just a hinge, it's a sliding dual hinge, which allows you to move this jaw forward, back, sideways, in any shape, any position. So if you bite here, maybe this starts to close a little bit while you're biting on something here. Kind of turns a little bit, turns this way. So people that have a denture with no implant support, or even with implant support, have a big tendency of understanding this more than others that don't, like people that have natural teeth. Simply because you bite on a tooth on a denture here, it acts as one tooth the entire thing, flips it out, flips it out, flips out. Big balancing act. You take it for granted when you have teeth that are all acting individually, that are fixed into the bone. Now, the other aspect of your jaw happens to be the musculature that is here. So there are patients that have overpowered their natural teeth. They start breaking their natural teeth. They blame it on food or something they bit, and the teeth can't handle it. The dentist comes along, puts a restoration in. Before you know it, they break that. And the reason why they break that is because they broke what nature gave them in the first place, and now they expect that dentistry is stronger than what nature gave them. That's totally not true. I would say never ever expect that we can out-compete what nature's already provided you. Now, if your jaw is too strong, you probably don't know it. And I find people, here's a very difficult combination. Somebody that's got a big, square, strong jaw, you see evidence that they're smashing their teeth together and they're hypersensitive to changes in their mouth. Very difficult patient to work with because every little thing, every little detail matters for them, and everything becomes very highlighted, very difficult to work with, and very difficult for you to get across to them that it's their sensory mechanism that is causing a lot of the problem. They're too strong of a jaw with a hypersensitive environment in their mouth, changes to crowns or fillings or the vertical dimension of occlusion. We're going to talk about that right now, which is called the VDO. So here's our 4 categories. We're on number 3, like I said, and here's the list of little items that we're going to be talking about within the category, trying to rate them between green and red. And the first one, like we said, is called the vertical dimension of occlusion, or shortened to VDO. Dentists understand this in concept, but don't always apply it. I'm going to kind of tell you how to look at your vertical dimension and see if it's more of a concern, and see if we can hopefully avoid tolerance issues. I think when people have a stronger understanding of the type of therapy involved and the musculature that's going on, and that can enhance the tolerance that's required to overcome that feeling of foreign biting and chewing and things, that once we give you a prosthetic, that's going to be a full arch piece. So here's just a regular mouth. Your green, fine, no big distance between arches here. As you go to yellow, you can see this one's becoming more collapsed. The teeth are getting smashed down, but the jaws still have some distance back here. You have some molars, so this is a turning into a collapsed bite situation. Definitely needs treatment. Definitely going to need about 12 or more restorations here to open this bite and hopefully protect them from crashing the teeth again back together. Here's where the bite becomes more and more difficult to deal with the more it comes over closed. We're going to talk about what we call posterior stops, but you can see here this person has some upper teeth back here but has nothing in the front and is completely collapsing his front teeth into the gum tissue of the upper jaw. So that's going to require a lot more opening and stretching of the muscles, and hopefully the patient would have tolerance to actually dealing with that because they have to have space between to actually put any kind of restorations on there. And the thicker the restoration, like a hybrid or some sort of overdenture, requires the most amount of space between those jaws to get you teeth into that position. Now, a repeatable bite, this is a little bit obscure, but I try to simplify it on what I'm looking for from a green to a red case. Bites, the patient bites with their back teeth. They understand where home is. If I say, can you bite on your back teeth? And they go, yeah, no problem, I just bite, you know. And they know where their teeth feel right together when they come together, and they go, yeah, well, that's why I bite. And they bite, and they just show you that they could do it every time. That's for sure in the green. Now, where does it become yellow to red? Well, it's when people are missing more teeth. How long have they been missing their teeth? Is it more in the back? Is it where in the front? Do they have the sensory enough awareness that when I ask them where are they biting, can you bite on your back teeth? And they go, sure. And they bite down on the front teeth, and then they slide it to the back. And I said, you know, or they just bite on the front teeth and go, I go, can you bite on your back teeth? And they go, oh. And then they realize. See, they're not even aware that they're biting in the wrong position after I just asked them. You'll see a lot of signs of flatness in their teeth, that they don't really understand where home actually is. And especially as you get into the red, they're missing teeth a lot longer. They don't have that sensory awareness. They bite anywhere they can to kind of chew their food. And as I asked them to bite on the back teeth, they just don't even know where that is, and they can't reproduce anything. So this really becomes important when you're dealing with full arch impressions and you send something to the lab. The lab only has a fixed position to start from. They don't have a person there to make the restoration, and you're making a full arch piece. Comes back from the lab, try it with the patient, it's completely off because the patient gave that information. Right? They bit down in the wrong position where they go, bite down, they go, huh? And they bite down. So then the teeth get put way back, come back, put it in the mouth, they bite at a different position, and they go, wow, the teeth are not even close. So that was a bad lab. No, it's not a bad lab. The lab was perfect. They made it to the position that the patient provided. Now, the doctor doesn't know where that position should be. The patient doesn't know where that position should be, so how is the lab supposed to know where that position is going to be? So there are some tools out there to try to figure this out, but it's a very difficult situation before you end up doing a whack-a-mole situation. Once you try this position, you try that position, you try this position, you try something called the deprogrammer that could help find that position of origin that's most native to the patient, but it becomes a very, very difficult thing, and it could turn into a cycle of back and forth in trying to do it. Sometimes I make something temporary and just give it to the patient, let them take it home, see where they feel comfortable with, and then we start to try to build on that too. That's another way I work on it. Bite classification. Bite classifications, class 1, 2, 3, and then another one we call edge to edge. Well, class 1 actually is not in the green. Class 1 is your normal bite where your upper teeth here come in, the lower teeth come right up in behind it. The only reason why I have this kind of more in the yellow and yellow greenish area is because you don't have a lot of gap room here, and if you're working on the front teeth, Well, if I'm working on front teeth and I have this malocclusion here where it's a severe class 2, meaning your upper arch is way in front of the lower arch, well, I can almost fix anything over here and it's going to work because they can't even bite on the front teeth. They can't connect to those front teeth. So that kind of saves you. So I'd say these are probably even easier than the class 1s. Now it's the class 3s and the class edge-to-edge classifications that become more of a concern. And you can see a result here on the red, which is the edge-to-edge. And there's also a cross-bite element to things too. Well, this person doesn't even know where home is. He's kind of grounded down. I put that deliberately to show you an edge-to-edge biter that slowly grinds their teeth down to having not any sensory at all. And you can see how chiseled flat they actually are. Class 3 just means that your lower teeth are coming in front of the teeth. And usually there's a cross bite somewhere in there, meaning the arches start to cross over. And that's a very difficult junction sometimes to actually restore once they chip or break that. And then you're trying to restore it back to looking normal, but you want to protect it so you make it a little shorter, then it doesn't look normal anymore. So it becomes difficult to actually keep a restoration in a cross bite or an edge-to-edge scenario. Here's chew patterns. Chew patterns are pretty important. When somebody has all their anatomy, I know that their chew patterns are straight up and down. They don't grind side to side, that kind of stuff. Now, when I start to see wear patterns on the teeth, I'm also looking for something called an abfraction, and that has to do with the chipping up at the gum line. And you can see it in this picture here, that they're chipping right at the gum line. That tells me that there's a lot of lateral force or side-to-side grinding. The grinders that I say go side-to-side chew more like a cow, and that the front to back is more like a rabbit. I don't know if that's true. I'm not a veterinarian, but I would say this person is probably doing a bit of both, but you can see wear patterns when you grind your teeth and you bring them together. You can see your own if you're doing this at home. Just go like this at the mirror, and you'll see they fit perfectly together. And now you know that's your grind pattern. And you can also go to the side. I don't have really a side grind pattern. I have tips on my canines and stuff, and it doesn't really fit or really grind flat. So I probably are more like a edge-to-edge grinder, or more like a rabbit or something, you know, like on the front. And then when you have severe wear and tear and chips and breaks and flat and everything else, like the last patient here, this is pretty severe here on the chew pattern. This is going down that direction as well. It's definitely a red, and you can see how severe that could be, and it's going to take a lot to restore that and protect it. So it's more about not just restoring it so they can get to the parking lot. It's about how are they going to get this to last after they've invested thousands of dollars to try to make sure that it's not going to happen again, but the etiology is still there, meaning their grind pattern and chew patterns are there. So that's where you come up with night guards and things like that to help protect it, possibly. But I find that most people actually grind in the day, not just at night. So be aware of that. Posterior teeth, posterior support, that's your back teeth. So, you know, here is green, you have back teeth, your jaw comes together, the vertical dimension's fine. Here's where it becomes more difficult. When we start to close it, but also in this case here, you can see that the upper teeth are exfoliating down, and it's closing out this space while that bone has resorbed down. Now, this case, we still actually have room. However, it's now created this kind of weird occlusal plane, the way your teeth come together. That could be problems, and of course, people always ask, why does it look so weird? Well, your upper teeth have moved into the position. And here completely is closed out, especially way back here. We don't go to a second molar position, but you can see that they're about biting on their gums on the lower jaw, while the front teeth over here have a full vertical dimension here. So this is a very difficult scenario to actually fix. And you're probably just going to end up extracting this back tooth down the road, because that will keep exfoliating but you can see how weird the crown will be if you can get something back here. It's going to be kind of tilted back, and it's just going to be a weird supportive kind of scenario. Failing front teeth. This is actually really important because patients assume it's bad dentistry or assume that there's a problem. It's usually not the case. It's usually that their lower jaw is just crashing into their upper teeth. And when your lower jaw comes into your upper teeth, it's hitting it at a lateral position. So you have a compressive load, which is up and down, something like this. But when you start hitting it to the side, you have a lateral push. So if this is the upper front teeth, you hit it like this, it's hitting sideways. It's much more difficult to restore things that are hitting in a lateral position. Here's a very simple fix. Somebody chips it off, no big deal. Usually that's just a slight trauma of some sort. Here it becomes very difficult because here it broke off because of a root canal treated tooth. Root canal treated teeth are all brittle, and it has a lateral load to that. This is pretty common, but I don't have a picture of the way the lower teeth come together, but typically if you're in a class 1 bite, comes in really tight down at the base, it becomes very difficult to start to restore and make sure that that tooth is going to stay in place. And this is illustrative of a really difficult case to fix, mostly because they're already almost biting on the gums here. They are biting way deep into the tooth here. They've got a lot of malocclusion here in the back, and they're chipping on the front. This is a very difficult to restore and make sure that the patient's comfortable and happy with what you're doing. But more importantly, how long is that going to last in a jaw situation that's just going to keep crashing and clashing with the muscles? If this person has a big square jaw, that's another red. That's not looking good. All right, combination syndromes for somebody that has an upper denture with a lower anterior or front teeth biting up against that ridge. What the problem is is that the gum tissue here starts to get really flabby. It's all because the lower teeth are hitting the denture in the front, primarily because that's where the patient has the most stability with a denture, but it's causing bone resorption in that upper jaw. As the bone resorbs, it doesn't mean that that fibrous tissue here is going to go away anytime soon. So what you do is you take an instrument and you check the flabbiness of that tissue, and the higher degree of the flabbiness, the more difficult it is for any kind of denture piece that's going to work into that position. And here's a very severe problem where it's very difficult, where the actual arches are not even in line anymore. He's lost so much bone on the upper arch, it's resorbed back, and the lower teeth are way out front. You're going to just offset and offload the entire denture piece or prosthetic and cause too much forces, causing fractures, breaks, and you can't really restore that long term very well. Not to actually then work. You're probably better off, in this case, just taking the rest of the teeth out, augmenting the lower jawbone to bring the lower jawbone back in a little bit, taking off a few centimeter, half a centimeter or something of the bone here. So now this jawbone starts to match up again with this, and that's a tough one to deal with. All right, TMJ, TMD, temporomandibular joint or temporomandibular disease. This is very vague. It's very symptomatic, case to case with the patient. I always believe what the patient has to say about it. They know their health usually better than I do, of course. But this one you just have to be mindful of and say, well, what is the patient described? Because that reality is what that patient, what their experience will be, that reality. So if they're describing that they have a very severe TMJ problems, they have chronic pain, they're in the red. If they just say, well, I have a click here and there, or whatever, they're a little bit concerned. They're more in the light green because clicks don't really mean anything. They think it does, but it's not really anything. 80% of the population has a click in their jaw when they open it. If this is more of a coaching thing, or you got to assess a little bit from a discussion with the patient how they feel about their jaw joint, and mostly comes into considerations when they're in for a long procedure where they have to open the jaw. But these patients know their situation, and they're going to tell you where you're at. So there you go. There's the third category. Hope that was helpful. And we're going to move on to medical dental history.